Good morning, guys. I think we need to start the meeting. We need to start the meeting. So let me see. Before we can start, let me just make sure. Yeah, I think I'm on. This is just a continuation of the anterior abdominal wall defects and also GIT defects. We covered a lot. We have covered a lot in terms of the GIT defects and also anterior defects. Today probably will be the last day. I just have a few slides to share with you concerning this topic. Then we'll finish anterior abdominal defects and hopefully we'll go into thorax and lastly maybe skeletal the placenta on the fetal defect series. So this is just a recap of what we covered. I always want you to have an image of this in your head whenever you think of anterior abdominal wall defects, that we have about five to six sets of the kind of defects we can get, starting the ones that affect the upper part of the abdomen close to the chest, which is pendology of Anterior, which is normally associated with ectopis cardia, where the heart is outside. Then we follow with exomphalos and gastroschisis. Exomphalos, we said there's a membrane covering, as shown here, and gastroschisis, there's no membrane. It's just the bowels floating the fluid. Then we do have body stalk anomaly, which is more for a very huge anterior abdominal wall defect. It's thought to be part of the amniotic bend sequence, amniotic rupture sequence, whereby the amniotic membrane ruptures very early in pregnancy and some body parts goes into the coronary cavity. As you are aware that the amnion doesn't fuse with the coronary cavity before 15 weeks. That doesn't completely fuse, right, before 15 weeks. So this is a very early kind of defect, which unfortunately in our setup, because of women booklet, we do see these cases in second, third trimester instead of diagnosing fifth trimester. Most of these defects, which I mentioned here, should be diagnosed in first trimester, not second trimester or third trimester, like in our case at the moment. Then we do have the cloacal extrophy. These are more like the lower abdomen defects, where we could have an associated exomphalos and also abnormalities in the iliac bones. As you can see that the position from the position of this baby's feet, and you could also have the genital tract being affected. You could have a bifid penis or widely parted labia. All these are defects that may occur. In addition to cloacal extrophy, we can also have bladder extrophy, whereby the bladder mucosa is exposed. It's not covered, the skin is not closed the way it should. So these are the defects that we would like everyone to be able to recognize and highly suspect. Because all of them, they are defects, if they are missed. I know gastroschisis and exomphalos, we have them in our units. if you go to the pediatric unit, neonatal surgical unit, abscess, a SALI or a PARI, you may meet these cases. You shouldn't be meeting them at PARI. They'll be in the wrong place. They should meet SALI. That's where the neonatal surgery is. So these are the defects that we would like everyone to recall. Yeah, so I think we went through the sonographic markers of all this in detail. But what I want to do now is to just continue where I left the day last week so that we can finish. Probably, let me start with the meconium peritonitis. I think we're rushing over this. So I'm going to start with the meconium peritonitis, then we can do the rest of the stuff and we finish. Right, so from current slide. I'm trying to share the bigger screen to go into slideshow. So the slide is coming. It's taking time. Anyway, the prevalence is about 1 in 3,000. That's how common meconium peritonitis is. How do you recognize it on ultrasound? Normally, we see what we call hyperechogenic bowel. Hyperechogenic bowel is something we are able to diagnose if we reduce the grayscale on ultrasound and the bowel is still as echogenic as bone. That's when we will say there is a hyperechogenic bowel. So be aware of that, that if you suspect that the bowels look a little bit echogenic than they should, you should reduce the gain scale, both the overall beam mode gain and the term gain compensation scales. You should lower them to almost 0 until you can only identify the spine bones, the vertebral bones. So if the bowel is as echogenic as the bones or the echogenicity persists, then that's a hyperechogenic bowel. So the hyperechogenicity comes from the peritoneal calcifications, and normally this results from in-rectum perforation of the bowel, which will result in a sterochemical peritonitis. We may see dilated bowel of loops, ascites, and also some meconium pseudocysts. This will be more like meconium collections that will look like cysts. That's what we mean by pseudocysts there. The incidence of chromosomal abnormality genetic syndrome is not increased. So if we are highly suspecting chemical peritonitis, we do not offer aneuploid screening. Then the risk of cystic fibrosis is about 75%. However, context matters. If you are dealing with a large Caucasian population, then in that case, you should be aware that they need to screen cystic fibrosis. Cystic fibrosis is not very common in our region, especially amongst the Black population. So it should not be the top suspicion on your list, but of course, you never know. It doesn't mean that Black people do not have cystic fibrosis at all. A rare condition can still occur. So always be aware of this. In terms of what we have to do, just a detailed ultrasound examination to look for other defects, including other markers of infection. Because infection can also result in a hyperechogenic bowel. And if cystic fibrosis is suspected, then DNA studies are required. So that means amniocentesis to be offered. Then the DNA studies can be done. Also, if the history suggests that both parents are carriers, then we have to do a torch. So remember, the hyperechogenic bowel, we do a torch. Even if they are to be referred to the fetal defects clinic, but you should order a torch so that when they come to the clinic, they already have a torch test. This is very important. I think this applies to what we have been trying to teach with other conditions like polyabdominals, where we are saying if you pick polyabdominals, when you refer the patient to the fetal defects clinic, you should make sure you've ordered a GTT or GTT or a glucose tolerance test so that when the patient comes, they have a result. The same applies here. Hyperechogenic bowel or fetal ascites, when you refer the fetal defects clinic, make sure you've ordered a torch so that when they come, they have a torch result already. This will shorten the suspicion to diagnosis time. Because if they come without a torch, we still need a torch because you can potentially miss an infection which is ongoing on the fetus. So the follow-up ultrasound scans every 4 weeks to monitor the evolution of the condition. On that statement, it is important that we recognize that babies' defects need a follow-up. How often you follow them up depends on the natural history of the condition, on what is known about the condition in terms of what it does affect on the fetus or the evolution of that condition. But you see that most conditions, besides the ones that are to do with issues of growth, placenta insufficiency, most of these conditions would like to, or the ones to do with the risk of fetal anemia, most of these conditions would want to follow them between 3 to 4 weeks. You should know this so that you have a rough idea, so that even when you are stuck and you are somewhere and you don't know how often you should be bringing somebody with a fetal defects, you know that roughly between 3 to 4 weeks, most of the conditions, it is suffices. Of course, this is not the same if you are dealing with a case of placenta insufficiency where there is already evidence of FGR, and also where you are trying to diagnose fetal anemia in conditions of recessive immunization or conditions of parvovirus B infection. Those babies, you may want to bring them earlier because 4 weeks may be too long a time. Delivery, again, at a place with neonatal intensive care and pediatric surgery. When should they come out? Around 38 weeks. Methods of delivery, induction of labor, aiming for vaginal delivery. You will see that most of the defects, they do not need a change in the mode of delivery. Natural birth is a good option for most of the fetal defects. Of course, there are outliers, like we discussed when we were doing the large exome values in the liver outside. You always fear that you could traumatize the liver. So in that case, cesarean is indicated. But most of the defects, natural birth is the way to go. This is very important because sometimes people may just be highly concerned that the baby is abnormal, hence they need to section. It's not really necessary in most of the cases. It doesn't help in terms of the overall outcome to just section everyone on the suspicion that the baby is abnormal. Then in terms of prognosis, in the case of simple peritonitis, the outcome is good and surgical intervention may not be necessary. In the case of complex peritonitis, which is associated with bowel dilatation and ascites, the prognosis is poor and neonatal mortality is more than 50%. In terms of recurrence, because this information is important when you are now counseling the parents, to say, will the condition come back? What will happen in our next pregnancy? The parents should know that the recurrence risk is not high here. And because it's more of isolated incidents and sporadic happening, so there is no increased risk of recurrence. However, the parents should always be encouraged to come for the routine scans, like the 11 to 13 weeks. They are normally scanned to check the baby's well-being, anatomy, and also well-being later on. Right, not visible gallbladder or non-visible gallbladder, whereby you haven't seen the gallbladder. I don't know when we did the abdomen whether we covered gallbladder visualization. If not, probably I'll put a slide of the gallbladder before next week's talk so that we can just appreciate the gallbladder. Most of you see it, but sometimes you may not recognize that you are looking at the gallbladder, but the location of the gallbladder is on the right of the liver. You are going to see the stomach bubble on the left, as always, with the abdomen. But on the right, if you go down on the liver, you are going to see a gallbladder, a cystic like structure, a cystic structure on the right. That is the baby's gallbladder. It just as you continue to slide your probe, when you're in transverse going down the liver, you will see it. Even if you are doing the image of the thorax, where you want to check the diaphragm, you sometimes see it on the right side, the gallbladder. It should always be seen. But in about 1,000 fetuses at 20 weeks of gestation, you may not see it. Some may say, why is it that we've scanned more than 1,000? We have had cases where we have not seen the gallbladder. But we may not have diagnosed them at that rate because people have not been looking at it. Because how it works, ultrasound, if the person who is scanning, the first person to scan, or the first want to deliver the service, misses the absence of the gallbladder, it is likely the absence of the gallbladder, it is likely that it will be missed, because once people say everything is normal, the next person who will be doing the review scan with the big growth will just make an assumption. So this is why we want everyone to be conversant with fetal anatomy, because the review cases normally are treated differently from first timers. So if you are seeing someone for the very first time, effort should be made to screen for all the major defects that we are discussing in our defects series. Because the first person to see the patient is probably the patient who is going to do the most detailed scan on that patient, except those probably who have been referred to special screening for one reason or another. But what I'm saying is, if somebody comes to right now in any of the units and they have a scan and they're just scheduled for another routine scan, the person is going to do the routine will assume that the anatomy was screened by the first person who saw the patient. So it is important that every one of us be conversant in screening of defects on babies, so that we reduce the false negative rate in our unit. So if it is small or an absent gallbladder, that's the suspicion of a non-visible gallbladder. It could be transient in about 75% of the cases. So if we don't see the first time, we don't become conclusive about it. But we are going to ask the lady to come back again so that we double check. So there's nothing wrong in asking the woman to say, look, I didn't see what I'm supposed to see in the abdomen. I'm supposed to see a gallbladder there, but today I didn't see it. But I didn't see it probably because the baby is in a bad position, or the baby just emptied its gallbladder. So I would like to double check again in 2 days' time or in a week's time to just make sure that the bladder is okay, the gallbladder is okay. So bring the patient back is quite normal in our work, because things like the stomach, the gallbladder, those organs empty. So sometimes you may not see a stomach because it is emptied, or the stomach may appear smaller than it should because it is just emptied. So it is normal to bring somebody back and say, please come back again so that I can see if the stomach or the gallbladder is there. If you don't see it, then in that case, it's likely that the gallbladder is missing or there are problems. So the causes of non-visualization of the gallbladder, if it is not a transient finding, which occurs in about 75% of the cases, it could be due to gallbladder agenesis or cystic fibrosis, and rarely biliary atresia. However, I've said rarely biliary atresia. However, my neonatal colleagues, I heard them one day saying they are having a lot of biliary atresia cases upstairs in the neonatal unit son. So be aware that probably we've been missing some of them, the biliary atresia cases, the non-visible gallbladder, but we should all be looking for the gallbladder whenever we see the patient for the first time. In about 25% of the cases of biliary atresia, there is associated with the heterotaxis syndrome. I think for those who work with us in the fetal defects clinic, we are aware that we've picked quite a number of heterotaxis syndromes, especially the left heterotaxy, and sometimes the right heterotaxy, where we have isomerism, and these babies normally present with bradycardia. So I think these are the cases we have also picked suspected biliary atresia where we didn't see the gallbladder. So whenever you don't see the gallbladder, it is a reason to refer the fetal defects clinic. Because sometimes diagnosing heterotaxy is tricky, and most people miss it actually, heterotaxy, because if you don't look at things at the level of the abdominal circumference and also at the level of the 4-chamber view, we are more likely to miss heterotaxy. So what we normally see with heterotaxy is that there is situs inversus, whereby the stomach may be in the left or on the right side of the left, instead of the left. I think we had a case like this last week, right? Is it last week or the other week? I can't remember. But we have a recent case of heterotaxy, whereby there was situs inversus. We have polysplenia. It's difficult to diagnose polysplenia, but you may see just that the spleen is larger than what it should be. The other things that we cannot diagnose on the scan is malrotation of the gut, and also intestinal atresia and the heart defects. That defects, of course, you pick on the scan. Like we were saying, that sometimes we have duplication of the left atrium and absence of the sinoatrial node, and these babies will have bradycardia. So, what is the importance of all this information? For us to be able to counsel patients, expecting parents, we need information. You need to know that if you pick heterotaxy or biliary atresia with heterotaxy, the couple need to know that there are certain things that may manifest after birth, which the scan is not going to reveal, like the issues of intestinal atresia, gut malrotation. They have other problems, these babies. It's not just the fact that the organs are sort of switched up. No, there are serious problems bedeviling these babies. In terms of investigation, detailed ultrasound exam, then we have amniocentesis to rule out things like cystic fibrosis, because it could also cause this. sometimes enzymes may also be assessed, enzyme quantity, but however, this is of very limited evidence to say you should do amniogenesis to start the enzymes in cases of biliary non-visibility of the gallbladder. The follow-up is standard and standard obstetric care and delivery. Then, unfortunately, because the diagnosis can never be totally cemented in uterus, it is always tricky to say what is it you have to offer this couple in terms of the prognosis to say, will the baby be okay? Will the baby need serious surgery? But postnatally, if biliary atresia is confirmed, unfortunately, this is a serious condition and will require liver transplantation, which we know in our setup, this is an extremely difficult situation for most couples, because they will not be able to go for this liver transplant. Gallbladder agenesis is a benign condition, so it's not a big issue as long as the rest of the biliary tree is normal. Because gallbladder agenesis may mirror people who have had a cystectomy or their gallbladder removed. So they should be fine. What it means is that they may not be able to handle a load of fat, but they will be okay in terms of overall health. So there's no increased risk of recurrence. Bowel. Small bowel obstruction. How common is it? 1 in 5,000 births. Of course, we have seen more than this because we are looking at the high-risk population, but bowel obstruction is fairly common in our units. How do we suspect it? We see multiple fluid-filled loops of bowel in the abdomen, measured in greater than 7 millimeters in diameter. The median gestational age of presentation is around 25 weeks and beyond. So what does it mean? That means it is possible to miss intestinal small bowel obstruction in second trimester anomaly scan. So if we do miss the bowel, this is why a 36-week scan is always important for every woman, even those with an anomaly scan, because we know that GIT defects can be missed in second trimester because most of them women face in the late second trimester after the woman is had an anomaly scan, which we do mostly between 20 to 22 weeks. So be aware of this. It's very important to know this, that bowel obstruction, you can potentially miss it in the anomaly scan, and it's a third trimester diagnosis. This is why even low risk, we should have a scan around 35, 36 weeks. We are not going to say every woman should have a scan, in late second trimester or third trimester, because I mean, the numbers needed to scan to just diagnose one case would be too much. The system will be overloaded. So, if you distinguish the bowel obstruction from other cystic issues, because sometimes if you are not aware, you could get a similar picture like this one in cases of multicystic kidney disease. You will see how the MCKD looks like. It looks almost like the picture on your right at the top there of bowel, but you distinguish bowel from the multicystic kidney, dysplastic kidney disease because of peristalsis. Normally, there is actually peristalsis when you continue to look at the bowel. If bowel perforation occurs, then the transient ascites and meconium peritonitis and also meconium cysts may happen. Polar abdominis, woman face after 25 weeks, but in most cases, it will be mild polar abdominis because some of the fluid will be absorbed in some parts of the intestine, like the duodenum, because the most commonest cause of obstruction of bowel occurs at the ileojejunal section of the bowel. So ileojejunal atresia is common in cases of small bowel obstruction. So polar abdominis, whenever you see polar abdominis in third trimester, try to make an effort to look at the bowels, make sure the bowels are not dilated. Associated abnormalities, the incidence of chromosome abnormalities is not increased, so we do not routinely offer amniocentesis to women with bowel obstruction. This is very important to know, because sometimes some people think that all the defects, you have to offer the woman amniocentesis. No, some defects, studies have already been done. A lot of cases have been reviewed, and people are now satisfied that not offering amniocentesis in cases of bowel obstruction wouldn't do more harm than good, really. Then other bowel anomalies, malrotation, gastroschisis, duplication, meconium ileus, they may be associated with obstruction. Then there is always a 10% risk of cystic fibrosis, and up to 90% in cases of babies associated with meconium peritonitis. Be aware of this, especially if you are dealing with a Caucasian couple or a Caucasian mother. Then investigations, ultrasound scan examination, detailed, and to look at all the other organs, make sure everything is fine. Then DNA studies for cystic fibrosis if both parents are carriers. Ultrasound scan every 2 to 3 weeks to monitor growth and assess amniotic fluid volume. Then amniotic drainage may be necessary if there is polar abdominis and cervical shortening. So be aware of this. I think some of you are very much aware now, because we've done quite a number of amniotic drainages for different causes of polar abdominis. So this is one of the indications. Delivery, again, at a hospital with neonatal intensive care and pediatric surgery. So perinatal and the UBH cannot deliver these babies. They have to be delivered at Sally and Mpilo. This is very important. In utero transfer is better than extrauterine transfer, because if babies are delivered at a center where probably 90% of the staff, maybe 100% of the staff, do not have the experience in handling such babies, then you know that it's a disaster for those babies. Yeah, so people may end up feeding those babies, not being aware that you don't feed a baby with suspected bowel obstruction because they do not have experience. So please take note of this, that those who are working at Sally, sometimes the specialists may overlook the delivery planning. So let's make sure that our fetal defects, the ones we are mentioning that they should deliver at a hospital with intensive care, let's make sure that we organize their in utero transfers to the right hospitals so that we do not end up with a bad outcome because babies have been delivered at the wrong center. So we are talking of gastroschisis, exomphalos, small bowel obstructions, and any other cysts in the abdomen which you are not clear with, including absence of the gallbladder. They should not deliver. They can continue their care at their respective fetal medicine units, but when they are about to deliver, their delivery should be done at the right hospital so that care is better for the babies. The prognosis is related to the gestational age of delivery and the presence of associated abnormalities in site of the presence of ulcer and the site of obstruction. In the case of large bowel obstruction, it's not common, but it does okay. There may not be polyhydramnios in the case of large, because most of the fluid will be absorbed by the small bowel, and there may not be polyhydramnios in these cases, but we may see obstruction, dilation of the bowels. In those babies born after 32 weeks with isolated obstruction requiring the resection of any short segment of bowel, survival is greater than 95%. This applies where the conditions are optimal and where the baby is delivered at the right center. Babies quickly deteriorate if they are not fed, even for 24 hours. They can go into both to be able to know the right amount to rehydrate a neonate requires training, extensive training. You have to go to school and be taught how to handle the fragile cardiovascular system of these neonates. So most people they think they know how to hydrate them, but you have to be trained how to handle these babies. So if they are delivered at the wrong center, dehydration will be one of their biggest complications, and electrolyte imbalance. Within 24 hours, it's enough to knock down these babies because they won't be feeding. If a mistake is done and they're fed, then they'll vomit in their lungs, and this will be the beginning of their end. So the survival is linked to one, they are delivered, and the immediate post-birth care that they are given. So this is why it is important for all of you to understand that you cannot allow a woman with this defect to deliver at the wrong center. Allowing them to deliver at the wrong center, that doesn't have the facilities like a death kill for a death tray for these babies. So, however, if bigger part of the bowel is lost during surgery, because sometimes there will be a bigger chunk of the bowel which is non-functional, then we end up in a situation where we have short gut syndrome, which is a lethal condition. However, some babies survive it, but they will have failure to thrive, malhandling of fluid, and fluid and electrolytes. So they will be needing some transfusion, some fluid infusions and so forth in life. So it's not a good thing for the short bowel syndrome. There is no increased recurrence risk with short bowel syndrome with small bowel obstruction. Large bowel obstruction is more or less the same. It's always very tricky to distinguish between the two in utero, but normally it is peripheral in terms of its location. It's not central like we see with the bowel obstruction of the small bowel. Right. I think I'm done with both anterior abdominal wall and GI conditions that we should know. Yeah, I think we've tried to be as exhaustive as possible. So I'll ask for any questions we may have on the topic, because we are leaving this topic. We are assuming it's done, and we are assuming that knowledge has been shared and some learning has taken place. And I'm also assuming that the next time it's not me who will be covering this session, but one of you guys will be doing it to the new, to the next generation of fetal medicine doctors and midwives.